right. Hi, my name is Marie. I am going to talk about a couple different projects today, just kind of briefly touch on a couple different ones. First, I'm going to start with a disease concept model that we've been working on, and then I'll go into a little bit of our natural history study. So a disease concept model, there are frameworks built by engaging the community to understand the drivers of symptom burden. These DCMs seek to identify the major symptom domains according to the caregivers and demonstrate what areas of life are most affected by symptom burden in both caregivers and the individuals. This has been done before. There are previous DCMs published, for example, in Angelman, STXBP1, and Parkinson's disease. All of these emphasize that these are patient-centered descriptions of the disease, aiming to understand what a successful future therapy would look like to the patients and to the caregivers, and trying to understand what endpoints are truly needed to make sure we are measuring the right things. A draft disease concept model was published a few years back with a really interesting approach. They looked at conversations taking place on social media, which allowed for a bit of insight into what families chose to talk about, ask advice about, commiserate about, celebrate about spontaneously. This analysis picked up a couple symptoms that was not recognized in the published literature at that time, namely an abnormal fixation on hands as an infant, or not being able to use their hands productively, and developmental, specifically cognitive regression with the onset of seizures. So this was accomplished by us approaching caregivers and inviting them to participate in a 1-hour interview with a focus on how caring for their loved ones with SLC6A1 NDD has impacted their lives and the lives of those around them. We wanted to know how families functioned, what symptoms made the functioning most difficult, and how that changed over time. Once the interviews were concluded, the recordings were digitally transcribed and anonymized. We used the Deduce software, which allows us to apply codes, like unifying terms, depending on what comes up in the interviews. There are major domains with subdomains within those. We then look at how those concepts are grouped or co-coded together to analyze what ideas caregivers are grouping together narratively. We had 547 individual codes to choose from, and our teams applied over 13,000 codes. To attempt to account for differences in coding and interviewing styles, the co-codes were applied per transcript. So if, for example, the concepts caregiver effort and seizures were co-coded together 10 times in one transcript, but only 3 times in another, they were each counted as 1 per transcript. And we had training provided to us and some members of the teams provided as a part of Combined Brain. So our caregiver participants, we collected 17 caregiver interviews, mostly from moms, but we managed to snag a few dads as well, and all were over 30 years old. The caregiver interviews represented 18 individuals with SLC6A1 NDD, exactly even with 9 boys, 9 girls. The majority of individuals were 5 to 11 years old at the time of the interview, but we were also able to hear from those with young children and a few from a group that is often difficult to represent, which are adults with SLC6A1 NDD. So, as you can guess from over 13,000 applied codes, there were a lot of concepts to potentially tell a story with. I wanted to make sure that we were telling the story the caregivers were telling, bringing out what they focused on in the narrative they told. The following results are still preliminary, and we are still deciding the best way to bring out the numbers. So the major caregiver domains, impact domains, are caregiver and family burden and diagnostic journey. These were each broken down into subdomains and distributed by caregiver identified impacts. Sections here are just weighted by raw code count. The major individual impact domains, so that's individual as in an individual with SLC6A1, are proximal and distal impacts, depending on if the impacts are on the body and self-care or if the impacts affect how the individual interacts with the wider environment. And this, again, it's just divided on raw count. And So next, we have the contributions of major symptom domains reported by caregivers. In the other section, we have cardiovascular, musculoskeletal, skin, and genitourinary. And again, this just represents the raw number of codes, but we can already see that behavior codes were used time and time again. So now we can start looking at how the codes get applied together. For example, we can see that in the caregiver impact heat map, we can see that behavior and neurologic symptoms are both co-coded with caregiver effort 76% of the time, but behavior also strongly impacts caregiver emotional and social domains. I also wanted to point out that sleep symptoms are going to most strongly impact the caregiver's physical health. For the individual with SLC6A1 NDD, caregivers discussed how the behavioral symptoms would impact the individual's social and family life. Maybe they have trouble in school or trouble making friends, but often it was a discussion on how the siblings are affected. These are the same major symptom domains and how they change by age group. The codes in this case were normalized against the total number of symptom domain codes to represent the percentage of codes within that symptom per age range in order to account for the difference in 5 to 11-year-olds versus every other group. Behavior symptoms remain a large part of overall symptom burden throughout the lifespan, but there are a couple times that it falls below another domain. The first is in the 2 to 4-year age group, when neurologic symptoms, namely seizures, are the more impactful symptom. But into school age and teenage years, behavior dominates the symptom domains. Likely this is partially because most get seizures under control by school age years. In adulthood, behavior symptoms fall and emotional symptoms rise, including things like anxiety, depression, psychosis, etc. I suspect that behavior symptoms never really went away. They just manifest in different ways with maturity, and family members and clinicians are more likely to name things differently in adults. For example, an aggressive outburst in an adult might be called psychosis, but in a 5-year-old would be called a meltdown. One encouraging note is that sleep gets better over time, or at least becomes less impactful. With the major contribution of behavior to the overall symptom burden, I pulled out the subdomains within the behavior domain and how they change over time. A couple things to note: social skill delays were most strongly recognized in the under 2-year-old group, but followed by the 18+ group. Interestingly, these are also the times when a regression in social skills were reported. Temper tantrums start out quite high in the toddler and school age group, but seem to fall off in the teenage and adult years. But I think this is, again, a naming difference as aggression rises in those groups. A couple concepts that were often mentioned in both caregiver and provider interviews were individuals getting stuck on a behavior or a behavior chain, and how unpredictable the behavior seemed, which was different from impulsivity, which was also frequently seen. As I said previously, there are many ways to pull this data together, but these are some of the symptom subdomains that were the biggest drivers of caregiver and family challenges while living with and raising an individual with SLC6A1 NDD. The biggest drivers of caregiver effort were gross motor skill disruptions, movement disorders, and fine motor skill disruptions. The biggest impacts on caregivers' social domains were disinhibition and having abnormal social behavior. The biggest impact on caregiver emotional health was maladaptive behavior, autism and autistic behavior, and unpredictable behavior. So just to wrap up the DCM, developing a DCM brings the caregivers and individuals most closely affected by a disorder into the research process. By doing this, we can establish goals for the natural history studies and clinical trials that most align with the lived experience. As targeted therapies are developed, this DCM will support the importance of behavior and emotional intervention across all ages. And while seizures and other neurologic symptoms have great impacts, they can't overshadow what caregivers have expressed to be the biggest barriers to education, socialization, sibling relationships, and caregiver health. I just couldn't have done it alone. A lot of people to thank. I probably forgot people, but we can't do this in a vacuum. And as I walk away, I just wanted to end with leaving some quotes from our caregiver interviews. There's a lot of really good ones. It was hard to choose, but you know, it explains what we're doing and what's important here. And that is it.